Welcome everyone to our webinar that's called Time is Brain, and to learn how to recognize a stroke and act fast to change lives and preserve lives. We are FreeOx Biotech, and we're a phase 3 biopharma company based in Barcelona. We're working on a groundbreaking therapy that is focused on the microcirculation of the brain, which is the missing piece in the emergency treatment for acute ischemic stroke. And we're aiming to become the first company to bring to the market the first drug in 30 years for stroke. The last drug was approved in 1996. Okay, we go to the next slide. So today's agenda is we are first going to explain what a stroke is. How do we recognize the signs? And then we're going to have the great honor of having testimonials from both a patient and a caregiver. And I'll give more details and present them in a minute. We'll explain why it's so important and crucial to act fast. And we'll talk about the medical need and emergency stroke treatment, the gaps in the treatment that exist today. And then we'll go to a Q&A session where you can ask any question you wish, and then we'll go to the closing words. Next slide. So today, the speakers and the panel, we have Dr. Ian Hitchcock. Ian is a medical doctor who trained in South Africa and now lives in London. He has a lot of experience in drug development in stroke, and he is FreeOx's Chief Development Officer and leading the effort to bring our drug to patients. We also have Nicolas Gerbeau here, and Nicolas will speak about his experiencing a stroke at the age of 18. And the second testimonial will be from Julia. Julia will share her personal experience with stroke through two family stories, illustrating how recognizing the early signs and acting fast can make life-changing difference. So thank you to all of you to be here today. And who do we start with?
We start with me. I think. Let me start. Good afternoon, everyone. Welcome and thank you for joining us. As someone living with stroke or caring for stroke survivors, you already understand how devastating that condition can be. So today I want to briefly review what happens during a stroke at the biological level, because understanding the mechanism helps us understand why rapid treatment is so critical. I'll present four sections today, starting with what is a stroke. The second is recognizing the signs. We will then hear from those who've been deeply affected by stroke, either themselves or their family members. I will then cover the third section, which is why it's important to act fast. And fourth, the medical need and emergency stroke treatment, followed by a Q&A session. So let me start off with what is a stroke. So a stroke is fundamentally a brain attack, similar to, say, a heart attack, but affecting the brain. There are two main types. There is an ischemic stroke, which accounts for approximately 85% of all strokes. This occurs when a blood clot blocks an artery supplying the brain. Within minutes, brain cells begin to die due to lack of oxygen and glucose. The area of immediate cell death is called the infarct core. Hemorrhagic stroke accounts for the remaining 15%, caused by bleeding into or around the brain when a blood vessel ruptures. Today, we're focusing primarily on ischemic stroke, where we have the most therapeutic opportunities. I want to address something called the ischemic cascade. So when the blood stops flowing to the brain, several damaging processes begin immediately. First, there's oxidative stress. The brain is particularly vulnerable because it consumes 20% of the body's oxygen, despite being only 2% of body weight. When oxygen delivery stops, harmful free radicals accumulate, causing cellular damage through a process called oxidative injury. The second process is called excitotoxicity, where neurotransmitters like glutamate are released in excess, overstimulating nerve cells and leading to their death. And the third is inflammation. The immune system responds, but this response can paradoxically cause additional damage to brain tissue. So we also talk about the penumbra concept, and the penumbra is the surrounding the core of dead tissue is the ischemic penumbra. It's brain tissue that's injured but is not yet dead, and it can be salvaged. And this is our treatment target. The penumbra can survive for hours if we restore blood flow quickly enough, but it is a race against time. So understanding these mechanisms helps explain why the treatments we'll discuss tonight work and why speed is absolutely essential. So section 2, recognizing the signs, if we can move on, Sandra. Recognizing stroke symptoms immediately can mean the difference between a full recovery and permanent disability. Every minute counts, literally. For every minute a large vessel stroke goes untreated, approximately 2 million neurons will die. So there's a well-known primary recognition tool called BFAST, and these stand for B is balance, which is sudden loss of balance or coordination. E is eyes, sudden vision changes, double vision, or loss of vision in one or both eyes. F is face, which is face drooping, especially on one side. Ask the person to smile. A is arms, so arm weakness or numbness, especially on one side. Ask the person to raise both arms. Speech, slurred speech or difficulty speaking. Ask the people to repeat a person to repeat a simple sentence. And T is time, time to call emergency service immediately if any of these signs are present. So I cannot overemphasize the time element. There's a concept, as Emma mentioned, in stroke medicine called time is brain. And researchers say that brain loss occurs at 2 million neurons per minute during a stroke. The therapeutic window for clot-busting medication, alteplase, or we call it TPA, RTPA, is 4.5 hours from symptom onset. The window for mechanical thrombectomy extends to 24 hours in select patients, but outcomes are dramatically better when performed within 6 hours. So beyond BFAST, what should we watch for? So with severe sudden headaches with no known cause are particularly concerning for a hemorrhagic stroke. Sudden numbness or weakness, especially on one side of a patient's body. Sudden confusion or dizziness or difficulty in understanding speech. And sudden trouble walking or dizziness. So what is not a stroke? Strokes are not always painful. In fact, with an ischemic stroke, it's typically painless, which is why symptoms are often dismissed. And strokes don't only affect elderly people, as we'll hear in a minute. They can occur at any age, including young adults and even children. And symptoms don't always resolve on their own. A TIA or transient ischemic attack may have temporary symptoms, but this isn't a medical emergency, as it normally is a signal for high risk for a major stroke. So if you suspect a stroke, firstly note what time the symptoms began. This is critical information for treatment decisions for the stroke team. 2, call emergency services immediately. Do not drive yourself or have someone drive you. If possible, number 3, bring up a list of current medications or the medications with you. And 4, be prepared to describe when the symptoms start and how they're progressing. So early recognition saves brain tissue. The treatments we'll discuss in this webinar, including novel neuro or seroprotective approaches, all depend on this first critical step, recognizing stroke and activating emergency response. And with that, I'll hand over to our patients and our caregivers.
Thank you, Ian. So we'll start with Nicolas.
Yes, sure. I wanted to express my experience with a stroke, as I had a stroke at the age of 18. So I'm a pharmacist. I'm 28 now, so it was 10 years ago. And I experienced a stroke when I was a student during my first year of medical study. Just to detail the progressive story of what was happening, the symptoms that came, and how I was taking a charge in a city in France, in Lyon. So I was every day working on my usual medical study, and I firstly feel temporary fatigue that was stopping sometimes and then came again. So I was supposed at the first time it was linked to just overwork and that I was needing some rest and nothing really important or serious. And then after several breaks, I first experienced like a first vertigo when I getting up from my chair. So at this point again, never nothing in my mind would just tell me that it was serious or something that could be linked to stroke as I was really young. So um, nothing really important at this point. Then I remember that I was looking at my body, looking at my hands, and just feeling that I was kind of losing the control. And this is at this point that some friends came to me and asked what was happening, and I wasn't able to express nothing, express fatigue or vertigo. And at this point, when I was speaking to them, they just realized that my speech wasn't really clear, and they just asked me, "Do you feel well? Do you understand that your sentence, that your words are not really clear?" And I wasn't aware of this. I think, I mean, I was feeling different, but I wasn't feeling specific pain, just fatigue. And because of this kind of alarm with this speech difficulty, I remember that I called my brother who was a medical doctor and just reacted very well because he was linking this symptom to a potential neurologic problem, even a stroke or something else. So he asked to my friends to quickly bring me to the hospital and to be able to have a diagnostic pretty fast. So my friends took me to the hospital, and this is when so I presented myself. The first symptoms that I had at this point, and I progressively expressed an hemiparesis. That means the half of my right body beginning to be less sensitive, and it was I had some difficulty to move, and I remember when I just presented my symptoms at the hospital, that just wasn't because I was so young. They were thinking it was linked to nothing like a drug substance or alcohol or something like this, but I was working, and so it wasn't this at all. And progressively, my state was worsening with the progressive hemiparesis, and then they start to suspect a stroke. So they did MRA while they was monitoring the evolution of my symptoms and my neurological attempts. And this, when they received the results of the MRI, they see an ischemic stroke that firstly was indicated for thrombolysis, what I undergo as a first step of my management, and then it wasn't sufficient as the recanalization was not complete. So I undergo in intensive care unit thrombectomy. as a second step of this management. And it allowed me to recover 100% of my sensitive and motor capacity, fortunately, several days after this thrombectomy. But just speaking in terms of timing, when I was speaking about my first vertigo and my first thrombolysis, it lasts approximately 4.5 hours, which is pretty fast. And fortunately, I was in the city that at this time was providing both thrombolysis and thrombectomy. So it helps me to recover the fastest and to have the best outcomes after this.
Thanks, Nicholas. That's really interesting. Sorry to hear that you went through all of this. Shall we move on to Julia?
Yes, hello everyone. Thank you, Nicolas. Can you hear me well?
Yes.
Yes.
Yeah. Okay, so from my side, I'd like to share two personal experiences involving two of my close relatives who both suffered an ischemic stroke like Nicolas, although not at the same age, obviously. So these are very different situations, but together I think it's important to share them because they show how crucial it is for everyone, relatives, family, friends, to be able to detect signs very early. So the first story, maybe I would say, is about my father. He was around 78 years old at the time. Regarding the signs, I think the first thing my mother noticed was his breathing, like very loud, very unusual. Also, he tried to speak as well, but no words were clearly coming out. So we immediately called the emergency services, and when they arrived, they also noticed that kind of half of his body was overall paralyzed. Also, he lost vision from one side. I think they used how do we say a light to a flashlight to detect. So basically, these were all the signs that we could notice. And also, I would like to highlight that besides the sides, there are a lot of cumulative delays that anyone can face in this situation because you need to wait for the arrival of the firefighters, then the emergency team, then they need to get the approval of an hospital for you to come. But then you also need to wait for the police to come and to escort the ambulance to the hospital to get there faster to avoid the traffic. So all of this sums up delays. And once you arrive at the hospital, there are also a lot of steps. So there is a scanner. I think there was a blood sampling as well. And then you have a medical committee meeting to decide what to do next. So everything takes time. In the case of my father, it was decided to perform a thrombectomy. And overall, I would say between the first signs and the time the thrombectomy was performed, it was around 4 hours, like Nicola. But in my case, I think it's quite long, but maybe I'm wrong compared to other management. But anyway, in the end, he survived, hopefully, but he had a very severe aphasia, from which he never really fully recovered. And well, no need to go into much detail, but it really breaks your daily life apart in this situation. And then I wanted to share another story about another of my close relative, and it was very different because he was only 40 years old, which made really the situation more unexpected because, as Nicolas said, you tend to think that stroke only happens in elderly people, which obviously it's not the case. So here I was the one to detect the signs. So my relative, he really seemed confused, really tired as well, as Nicolas said. And basically I asked very basic, open-ended question. And he answered like, yes, which was really out of context here. So the fact he was not able to answer a very basic question, this is really what alarmed me. So we were in the countryside, but very, very lucky enough to have a hospital very nearby. So we went by ourselves directly to the hospital, and the staff immediately detected that something was wrong. So he was managed very, very quickly. And in his situation and in this small hospital, he had only a thrombolysis, not thrombectomy. But I would say between the time of I detect the signs and the thrombolysis, maximum 1 hour had passed. So it was very, very fast. And as an outcome, he also experienced aphasia, and he had to completely relearn how to write, to read. But I mean, in 3, 4 months, he recovered everything. So the outcome was very, very positive. So I think the two stories are interesting. Obviously, I assume brain plasticity is not the same at 40 and 80 years old. And obviously, it plays a role in the recovery potential. But still, to me, it really stands out to me that how it is absolutely critical in terms of speed of management and to really detect the signs, to react quickly, and it really can change or make a difference in the end.
Thanks, Julia and Nicola, for that really insightful talks. It's very helpful. And I think let's move on to the next section, Sandra. So, and I think you've highlighted really why it is absolutely critical in stroke treatment and what happens in those precious hours and minutes. So the biological clock, from the moment a cerebral artery occludes, or a large cerebral artery, in the first 5 minutes, the neurons in the core infarct begin dying. From 15 to 30 minutes, the penumbra becomes established. That, as I said, is tissue that is injured but is salvageable if treated correctly. From hours 1 to 3, the penumbra progressively shrinks and more tissue becomes irreversibly damaged, highlighting how quickly this needs to be treated. And from about 6 hours onwards, the penumbra may be largely lost, leaving minimal salvageable tissue. So research from pooled clinical trials demonstrates that for every 15 minutes delay in treatment with thrombolytics, there's a measurable reduction in the likelihood of an excellent functional outcome. So the currently approved treatments at the moment have strict time windows based on this biological reality. Although there is research ongoing to say that there is still benefit to give them some of them later. So we've heard the talk about intravenous thrombolysis, and this is a drug called alteplase or RTPA, and it's licensed to be given within 4.5 hours of symptom onset, although there is some published data now that shows that it can be given up to 24 hours and still derive some benefit. But the maximum benefit is derived within the first 90 minutes, or the first golden hour, as they call it. And the effectiveness just decreases progressively with time. So for every 15 minutes delay, the odds of a good outcome decrease. And we heard both Nicola and Julia talk about mechanical thrombectomy, and this is where the clot is removed using specialist medical devices from the vessel, and it is mostly effective in large vessels within 6 hours. It can be performed up to 24 hours. It's carefully selected patients with favorable imaging, and it represents a major advance since 2015, with 5 landmark studies proving benefit. So with looking at real life data, so in the Hermes study, which is a meta-analysis of these thrombectomy studies, patients treated within 3 hours had approximately 3 times better odds of functional independence compared to those treated at 6 to 8 hours, even though both groups received the same treatment. It's not because doctors' work is less effective, it's because much of the brain has already been lost. So time is brain has been quantified by Dr. Jeff Saver in the US, And he said, that published data that large vessel occlusion stroke, about 120 million neurons are lost per hour. That's equivalent to 3.6 years of normal brain aging per hour. So it's an enormous impact on the brain. So with each hour of delay, approximately a 10% reduction in likelihood of an excellent outcome occurs. So we heard about what Nicola and Julia said about the pre-hospital considerations. So speed begins before hospital arrival. So some countries now have mobile stroke units with CT scanners, which can reduce the time by 30 to 60 minutes. Paramedic notification allows to prepare stroke teams, and direct transfer to a comprehensive stroke center bypassing smaller hospitals may be appropriate for suspected large vessel occlusions. So then why aren't current treatments enough? So despite restoration of blood flow with thrombolysis or the mechanical thrombectomy, less than 50% of stroke sufferers achieve functional independence, and we measure it by a score called the modified Rankin scale of 0 to 2. So reperfusion, when you open the vessel, doesn't guarantee tissue salvation. Oxidative damage, inflammation, and microvascular dysfunction occur even after recanalization. And we call this futile recanalization. The blood flow is restored, but the tissue still dies. And this makes the case for what we call neuroprotection or cerebroprotection. And this is why we need adjunctive treatments alongside the current reperfusion therapy. If we can reduce the rate of tissue damage during this critical period, the therapeutic window might be effectively extended. Outcomes after successful recanalization may improve, and patients might tolerate slightly longer treatment delays. So speed matters was the biology won't wait, but speed alone is not enough. We need both rapid reperfusion and protection of vulnerable brain tissue that we can salvage and return to normal. That's the future direction of the stroke treatment, and combining mechanical recanalization with neuro or cerebroprotective strategies. So what I'll cover in the final section is the medical need in emergency stroke treatment. So despite these advances of thrombolysis and mechanical thrombectomy over the past decade, significant unmet need in stroke particularly remains. So I will outline where we are today and where we need to go. So as I said, the intravenous thrombolysis was approved in 1996. Currently, only 10 to 15% of patients receive this due to a narrow time window, the need for a scan to establish that it is an infarct and not a hemorrhagic stroke. And recanalization of large vessels occurs in only about 30 to 40% of cases where patients receive only thrombolysis. There's also a risk of hemorrhage, which is approximately 6%. So mechanical thrombectomy has also revolutionized care since 2015. And there were 5 landmark studies which are often quoted. There's Mr. Clean, Escape, Extend IA, Swift Prime, and Revast proved that mechanical thrombectomy had a dramatic benefit. It achieves recanalization in about 75 to 85% of cases. And the number needed to treat is about 3 to 5 patients per functional independence. But there's limited availability of MT, only appropriate for large vessel occlusions, which are about 30% of ischemic strokes. So outcomes still remain suboptimal. Even with the best treatment, only 46% of thrombectomy patients achieve functional independence at 90 days. 54% will have significant disability of death. And amongst those with successful recanalization, 30 to 40% still have poor outcomes. And this is due to what we know as futile reperfusion. So why do outcomes remain poor? So several mechanisms continue damaging the brain even after blood flow is restored and oxygen has got into the area of ischemia. The first is oxidative stress. So free radical damage continues during and after reperfusion due to the rapid inflow of healthy blood. The reperfusion injury the restoration of blood flow paradoxically causes an additional inflammatory damage. And then we have microvascular dysfunction. So the capillaries, which are the small vessels which drain the area of the brain, remain obstructed despite the recanalization of the large vessel. And we get this no reflow phenomenon. So all the toxic things which are causing cell death cannot be removed from the site of the injury. So then we also have hemorrhagic transformation, where the damaged blood vessels leak, causing secondary bleeding. And all of this adds up to further damage to the brain. So what we need to address, as Emmett said, is this neuro or cerebroprotection gap. So over 1,000 neuroprotective agents have been tested in experimental stroke models, and nearly all have failed in clinical trials. And why is that? So the historical failures include calcium channel blockers, NMDA receptor agonists, free radical scavengers, and anti-inflammatory agents. And the reasons for failure of these agents is that they're often administered too late. They're tested in patients without reperfusion injury. There's a poor mechanism of molecular mechanisms and inadequate drug delivery to the ischemic tissue. They're also very heterogeneous patient populations without biomarker selection. So the paradigm shift that's occurred in recent years has brought a new understanding. So cerebro or neuroprotection must accompany reperfusion, not replace it. Ultra early treatment is essential, so ideally pre-hospital in the ambulance or during thrombectomy. So mechanism-based selection of agents targeting oxidative stress, inflammation, or specific pathways is essential. And patient selection using advanced imaging to identify that they have salvageable penumbra. You can't go giving alteplase thrombolytics to patients with a hemorrhagic stroke. It'll simply make it worse. Therefore, they need to be scanned. So specific unmet needs include seroprotective agents that reduce infarct growth during the critical period before and during treatment for patients ineligible for thrombolysis or thrombectomy, which is the majority of stroke patients, and strategies to reduce hemorrhagic transformation after reperfusion therapy. Agents that protect microvascular perfusion and prevent the no reflow phenomena that are described, and treatments effective in a broader time windows for patients with wake-up stroke or uncertain onset times. So there's several emerging approaches that are under investigation, including OXO1 that Emmett mentioned. But the regulatory and evidence challenges remain. So demonstrating of efficacy of adjunctive neuroprotective agents requires large studies, typically, between 600 and 1,200 patients, and proving benefit beyond state-of-the-art reperfusion therapy. So these agents need to be added to our existing therapies, which are thrombolysis and mechanical thrombectomy. They need rigorous safety standards, particularly regarding bleeding risk. We can't see an increase of bleeding in these patients. And outcomes that matter to patients and regulators. So that's what the patient can do functionally after the stroke, and not just surrogate markers, which are the size of the infarct on brain scan. It must be that the patients can restore their normal life as much as possible. So to sum up, we've made extraordinary progress in stroke treatment, but half of our patients still face disability despite our best efforts. So the next frontier in stroke treatment is seroprotection, safeguarding vulnerable brain tissue during the critical window. This requires agents with proven mechanisms, optimal timing, appropriate patient selection, and rigorous clinical trial evidence. The field of treatment is becoming far more hopeful, from failed trials to mechanism-based approaches, from monotherapies to combination strategies. And this is always stroke care is heading, and where patient advocates can play a crucial role in supporting research and trial participation. And with that, I'll hand back to Emmett.
Well, thank you very much, Ian. Very interesting. And thank you to Nicola and Julia for your testimonials. It's really fundamental, and we learned so much from it today. It sparked some questions from the audience, and so we received a few questions already. I'd like to share them with our panel, with our participants. So the first one is, we've heard that stroke could occur at any age, which I didn't know. Nevertheless, how does age or lifestyle affect the risk of having a stroke? I guess that one's for you, Ian.
Yeah, so with stroke, there are a number of factors that we score really, which are things that are modifiable and things that are not modifiable. So the modifiable risk factors are older age, male gender, non-white genetic background, family history, or prior stroke or transient ischemic attack. Now, the modifiable factors which we can all take care of in our general day-to-day health and is really important are things like hypertension. It's important that it's treated. Diabetes, atrial fibrillation gives you a 5 times higher chance of stroke. Carotid artery disease, dyslipidemia or high cholesterol, cardiac disease, and then we know cigarette smoking, alcohol, obesity, and the general things that we should take care of with our health. Probably the most important one is the previous transient ischemic attack, which is an important risk factor for stroke. And hypertension is the most prevalent. Nicola, did you have any signs that you before that you were potentially you could suffer a stroke, or was it the first time that you experienced an event?
All the signs and symptoms were the first time in my life I experienced those. Only maybe the first hours when I experienced just fatigue and yeah, kind of losing control with vertigo was pretty similar to a deep fatigue feeling, but all other symptoms were really specific and new to me.
And Julian, your family, were there any TIAs or anything that you recognized before the strokes?
Not really. My father, he was a heavy smoker all his life, so I guess it's a major risk factor. And for my 40 years old relative, afterwards, they searched for the cause and actually he had a cardiac bicuspidi, like a cardiac anomaly linked to weakness of vessels and an
Mm-hmm.
artery that caused the clot to rise. So it was not really linked to the lifestyle. Although he worked a lot, so maybe there was stress as well.
Mm-hmm.
Don't know.
It's a big one, stress, right?
Mm.
And
And yes, Nicola,
yeah,
please go ahead.
yeah, just to complete, because I wasn't directly answering the question, but for the etiology of my stroke, it was discovered after this that I had oval foramen, like a patent foramen between the two hairs of my heart that have been closed after this. So I had no risk factor at the beginning, but this just discovered it was the most possible reason behind this, and it has been closed after my stroke, the year after this.
Great.
Yeah, thank you.
Yeah.
I have a follow-up question to this one because, Ian, does gender have an impact or have, either on incidence or on outcomes? What about the difference? Because I think the three cases that we heard today are males or men. How about women? Is there anything to say about women, Ian?
Yeah, so more men have strokes than women, but the outcomes from men, with research that was done, showed that the outcomes from men are actually better. And there are various hypotheses for these,
Oh,
and one of them is based on why OXO1 is being developed, and men generally have a high uric acid because the women's estrogen causes it to be excreted from the kidneys. So women seldom get gout or the symptoms of hyperuricemia, which is chronic exposure over a long period to uric acid. And it was noticed in large epidemiological studies that men with higher uric acid had better outcomes from stroke. So it definitely plays a role, although so men are more susceptible to strokes than women.
I recently saw a publication that said that in France, actually, stroke was the number one cause of death in women, which I was surprised to see. Okay, the second question from the audience. So both panelists were with someone when they had their stroke. What about if I'm alone? How can I realize I'm having a stroke? And what should I do?
Yeah, that's a tricky one because these things come suddenly. But it's all about education and things like that. So the self-recognition clues are if you have kind of any difficulty speaking or understanding your own thoughts, sudden vision changes, loss of vision, double vision. I think Nicola described that fairly well, or kind of any visual field cuts really. Severe sudden headache, unlike you've ever experienced. A sudden loss of balance or coordination, we heard that from Nicola as well. Difficulty walking or standing or vertigo. And then sudden weakness or numbness affecting one side, which we also heard described very well. So if you're alone, I mean, the first thing to do is to recognize your symptoms, is to call emergency services. This is not something that should be dealt with. If you are feeling very poorly, I think a minimum amount of information should be given to them. It's like, I think I'm having a stroke, and provide your location. You should not drive yourself to hospital. You could lose consciousness driving. That could make it a lot worse. If you can, you should unlock your door, if possible, before symptoms worsen, to allow emergency personnel in, and note the time. It's critical for treatment from the stroke team that they know when the onset of this was. We've heard both Julia and Nicola describe that. And sit or lie down safely to prevent falls if you lose consciousness. So if you have stroke risk factors, and as a lot of people do, and especially they live alone, you should consider things like medical alert systems, regular check-ins with family and friends, keeping emergency contacts visible near phones, or pre-programming emergency numbers into your mobile phone. And I think Nicola described the West as stroke symptoms often feel odd or not quite right. And then, rather than dramatically painful, you need to trust your instincts. And if something feels wrong or severely wrong, you should call for help.
Thank you, Ian. Next question from the audience. What are the current limitations in emergency stroke treatment?
Well, I think we've discussed some of that already. The limitations are that it happens very quickly. You lose approximately 2 million neurons per minute. The ischemic penumbra is salvageable brain tissue, but it progressively shrinks. In other words, the amount of tissue that you can salvage shrinks as time passes. The treatment effectiveness declines with time. Intravenous thrombolysis for every 15 minutes of delay. The likelihood of excellent functional outcome decreases. So the golden hours, the first 90 minutes, hour and a half, is important. And mechanical thrombectomy, once again, the earlier that it's done, the better. And I described the Hermes data where patients treated within 3 hours are important. But if things are delayed, so the infarct area increases, oxidative damage increases, the inflammatory cascade progresses, the microvascular dysfunction worsens, and the hemorrhagic transformation risk increases. So it's firstly the importance in time. Secondly, the drugs and medical devices we have improved things, but there's a huge unmet medical need for cerebroprotection to be given either before in the ambulance or during the mechanical thrombectomy. And there are lots of studies that are ongoing to address this. And we're participating in one which is run by the NINDS division of the NIH in the US called STEP, where they'll look at a number of interventions, including OXO1, to improve the outcomes of stroke. Some are medical devices, some are medical products. And we're hoping that there can be the next paradigm shift in the treatment of stroke from this study.
Thank you, Ian. And with regards to mechanical thrombectomy, I think that Julia and Nicolas mentioned it. Access to mechanical thrombectomy is not equal across different geographies, if it's a rural area versus a city, etc. So I think that probably access to mechanical thrombectomy is steadily improving, but is still not where we would like it to be.
Yeah, mechanical thrombectomy is only appropriate for about 30% of ischemic strokes, those that have large vessel occlusions, but you need imaging to make that diagnosis. And there was a study recently that changed the design of the STEP study that showed that patients with smaller vessels don't benefit from mechanical thrombectomy. So, as I say, it's a small group of patients, but you also need an agent which you can administer and not do any harm to the patient. And that's what we're exploring as well with OXO1, is that if it's given to patients in resource poor areas, or where we don't have scanning for instance, that you don't do any harm to the patient.
Right. It's a small group of patients, but large vessel occlusions where mechanical thrombectomy is indicated also have devastating effects, right, Ian?
Yeah, absolutely. And as I say, even with the current treatments, more than 50% of patients have residual disability. So there's a huge room for improvement.
Great. Well, I think we've come to the end of our time. Thank you so much, Nicolas and Julia and Ian. We look forward to our next webinar. And what is the theme of our next webinar, Sandra?
It will be about how to recover from a stroke and what are the impacts of the stroke when we don't have the chance, as Nicola and Julia, to recover as well as this indication.
And the date?
It's December 2nd at 6:30 CET.
I think it's a Tuesday, right?
It's a Tuesday, yeah.
Yeah. Thank you, Sandra. Well, thank you all for attending and for your questions. I hope you found this instructive and you learned something and you enjoyed your time during this webinar. Thank you and have a nice evening or afternoon, depending from where you're connecting.
Thank you, and thanks again to Julia.
Thank you.
Thank you all.
Thank you. Thank you so much.
Bye-bye.